Today we will look at respiratory noises in children, in pediatrics, in clinical pediatrics. Newborn. In newborn, on day 1 to grunting can occur. Grunting is an expiratory noise. Forceful expiration against partially closed glottis causes grunting. Grunting is present in older children also, in infancy, in children. The word partially closed glottis is important. This is grunting. If in OPD somebody is grunting, he should not wait. While going through and you listen somebody is grunting cry, some child, then you have to take him first, because that baby needs urgent attention. Grunting is done to increase the intra-alveolar pressure to prevent collapse. When the alveolar collapsed, every breath becomes sternus. Every breath becomes difficult. Every breath requires exertion. Normally, breath should be effortless. Breath should not be visible. Grunting baby has distress. Then we'll have to differentiate causes of grunting at various ages. They differ. In premature and newborn, surfactant deficiency, prematurity, inadequate opening of alveoli at the time of first cry. The first cry is to inflate alveoli. यानी फर्स्ट क्राई क्यों मैं इस दुनिया में आया करके बच्चा रोता नहीं है. Baby creates a sound to inflate the lung, to take deep breath after every cry expiration. Cry is always expiration. ऐसा क्राई नहीं होता, ऐसा क्राई होता. Cry is always expiratory. Talking is also expiratory. सिर्फ महादेवन इंस्पिरेशन में टॉक कर सकता है, गाना गा सकता है, नॉन स्टॉप महादेवन. वो इंस्पिरेशन में भी गाना गाता है और एक्सपिरेशन में साउंड करता है, गाना गाता है. लेकिन नॉर्मल आदमी, ये योगी लोग कुछ भी कर सकते हैं ना, वैसा वो योग साधना है. ही हैज एक्वायर्ड दैट स्किल ऑफ सिंगिंग इन इंस्पिरेशन. दैट्स व्हाई नॉन स्टॉप महादेवन गाना गा सकता है. लेकिन नॉर्मल में वैसा नहीं होता. नॉर्मल में एक्सप्रेशन में ही साउंड प्रोड्यूस होता है. लेटर ऑन रेस्पिरेटरी इन्फेक्शंस, irritation, inflamed respiratory mucosa, secretions reduce the surface tension and alveoli can collapse. In infection and even in asthma. The last stage is grunting of the respiratory distress. When a first stage is increased respiratory rate of respiratory distress. Second stage is intercostal muscle indrawing. Third stage is grunting. And fourth stage is respiratory failure or ventilatory failure. So, grunting in total has to be looked as per age-wise. Differential diagnosis differs age-wise. Next is noisy breathing, congenital laryngeal stridor, starts around 15 days to 1.5 months, maximum around 3 months also, resolves by 3 to 6 months automatically, 100% resolution by first birthday. Congenital laryngeal stridor has to be differentiated from laryngotracheomalacia. Laryngotracheomalacia is a pathology and congenital laryngeal stridor is physiology. Congenital laryngeal stridor is due to inadequate calcification of cartilages, maybe due to prematurity, maybe due to hypocalcemia, maybe due to vitamin D deficiency. But respiratory rate is normal. In congenital laryngeal stridor, respiratory rate is normal because it is physiology. It is not pathology. There is no distress. There is no indrawing. The amount of stridor is a inspiratory sign. Wheeze, grunting are expiratory. Stridor is inspiratory. And it is due to kinking of trachea or windpipe. It is due to kinking. It is positional. Congenital laryngeal stridor can be diagnosed or differentiated by position of the head and neck and trachea. We have to ask the history. Sometimes you listen, there's such a loud sound that the baby's sound, laryngeal stridor, is heard in neighboring room. Inspiratory sound. And sometimes you put your ear near child baby's mouth and the sound vanishes. It vanishes because there is no illness. The pathological sound will not vanish with position. This change of sound or absence of sound in certain position confirms the diagnosis of congenital laryngeal stridor. Many times in newborns and infancy, we don't know whether these respiratory sounds are laryngeal throat sounds or lung sounds. Laryngeal and throat sounds change with position of the head. Lung sounds, creps and bronchi, will not change with position of the head. While you are auscultating a baby is sleeping and you don't know whether these are chest sounds or throat sounds. Gently turn the head If the sound changes, it is not lung sound. If sound remains same, it may be lung sound. So that is the way of differentiating clinically, bedside, whether the sound is from throat, larynx, trachea or from chest. No treatment is required for congenital laminal stridor. It is physiological. Maximum you can give prophylactic dose of vitamin D, prophylactic dose of calcium, exposure to sun rays, which will convert transcutaneous vitamin D will be prepared. But generally it is physiological, it is cures by itself. Main is respiratory rate is normal. That and TPR is normal, temperature, pulse, respiration normal. So that is congenital laminal stridor. Next is laryngotracheomalacia. It is a pathology. Laryngotracheomalacia may be due to inspiratory, expiratory, both. It is abnormal calcification of larynx, trachea, both. Whenever larynx is involved in any disease, there may be hoarseness of voice. If there is no hoarseness of voice, larynx is clear. For example, acute laryngotracheobronchitis, viral or bacterial, may have hoarseness of sound. That is due to vocal cord inflammation or laryngitis. We will come to acute laryngotracheobronchitis later. At present, we are at laryngotracheomalacia. Laryngotracheomalacia can be of various severity. The milder form, growth is normal. There is no hypoxia, but there can be intrigue. There can be distress. There can be increased respiratory rate. It is pathological. But there is no infection. All laryngotracheomalacia don't have indication for direct laryngoscopy. But whenever there is diagnosis in doubt, direct laryngoscopy is useful. And ENT surgeons can do it. We also can do it if we are used to do it. We have done it. Direct laryngoscopy is not very difficult. It is as difficult as seeing tympanic membrane, and it is as easy as seeing a tympanic membrane. It is as difficult as seeing a fundus, and it is as easy as seeing a fundus. So it's a question of practice rather than any other knowledge. It's not a question of knowledge. So having knowledge is not enough. We have to have practice for that. So congenital laryngotracheomalacia is chronic hypoxia. Chronic hypoxia is failure. The children come with failure. There are many differential diagnoses. Aberrant laryngeal artery. It presses on larynx and causes that. cysts, vocal cord cyst, not very uncommon. Laryngeal cyst, webs, they are congenital anomalies, developmental disorders, embryonic in origin, but they have to be diagnosed rarely. At this point, at BCH level, we should be aware of cry-do-chat syndrome. Deletion on chromosome 5 is the cause of cry-do-chat syndrome. There is no hoarseness in cry-do-chat. It is winning cry like a cat. Very rarely, hypocalcemic tetanic can have cry-do-chat. Snuffles is also a respiratory sound. Nasal snuffles, nasal stuffing, or adenoids, or in older ages, times there was congenital syphilis, which was very common 25-30 years ago. Now you don't see any congenital syphilis. Awareness of venereal diseases, use of आपको जाना है क्या? कॉल है क्या? हाँ जाओ, हम कंटिन्यू करें. इमरजेंसी इज इमरजेंसी. इसका लाइफ सेव करना अपना पहला काम है, सीखना बाद में का काम है. जाओ. स्नफल्स, congenital syphilis, anemia, hepatosplenomegaly, shining sores, anal tags were indicating congenital syphilis. VDRA positive, mother positive, curable, penicillin, 100% cure. That comes in congenital infections. Maybe like the presentation congenital tuberculosis, congenital malaria used to be there, now it is not. Wheeze and rhonchi. Audible rhonchi or wheeze. Wheeze is a symptom. Rhonchi is a sign of bronchospasm. Bronchial muscles are not developed before 6 to 9 months. Bronchiolitis will have bronchi, respiratory distress, hypoxia, indrawing, but bronchodilators are not very useful because there are no bronchial muscles for bronchodilators to act. So mainstay of bronchiolitis management is hydration and oxygen rather than bronchodilator and steroids. But in asthmas, bronchodilators, steroids inhaled are better and useful. All that wheezes is not asthma. There are many causes of wheezing other than asthma. So we have to know differential diagnosis of wheeze or rhonchi at various stages of childhood. Bronchiolitis is viral. Respiratory syncytial virus and other viruses. Asthma is hyperactive airway disease. More allergic than infective. But infection can precipitate asthma. Infection can complicate asthma. But infection is not equal to asthma. Somebody can have a severe asthmatic attack without any infection. It is antigen-antibody reaction, allergy. Short-term bronchodilator, long-acting bronchodilators, steroids, inhaled oral, injectables, depending on emergency situations. But we have to differentiate between whether the problem is inspiratory or expiratory in older children. Then the diagnosis is very clear. Normally, inspiration is longer than expiration in respiratory cycle. Inspiration is voluntary, expiration is involuntary. The ratio is 3:1. 3 part inspiration, 1 part expiration. Some asthmatic children have no rhonchi, no crepes, still there is bronchospasm. They have prolonged expiration. So you listen. Expiration is longer than inspiration. This finding indicates that there is bronchospasm. Expiration longer than inspiration is pathological. Normally, inspiration is longer than expiration. Auscultating baby, a crying baby, requires skill, training of ears. Ears hear, brain understands the meaning of that sound. So, auscultation is understanding the meaning of the sound heard by our ear. So, auscultation is training of brain rather than ear. Best way is auscultating a sleeping child. Auscultate in all quadrants. You should be comfortable. Mother should be comfortable. Baby should be comfortable. When our diagnosis is dependent on auscultative techniques. When it is not dependent on auscultatory findings, then other findings can tell you what is the problem, diagnosis. But there are times when without auscultation we don't know what it is. Typical example is reduced breath sounds. Normally breath sounds are equal on both sides, but they are reduced on one side or pathology on that side, on the side where it is reduced. So we have to compare right and left lung inspiration and expiration sounds. So baby has to be quiet. Very, very rarely we have to examine under sedation. We don't know the diagnosis. Other findings are not telling us the diagnosis. Auscultation is the only way to confirm the diagnosis. In that case, you can give pediclory, ask the mother to feed the child and sit in a corner, and then you go to the baby, you sit near the baby by telling mother that don't disturb the baby, don't wake him up, I will do whatever I want, I don't need your help. You don't make any movement, I will auscultate myself. I want to auscultate nicely. You can examine a sleeping tiger. Once the tiger wakes up, he will not allow to examine you. तो ये माँ को बताया तो उसको भी हंसी आती है, हाँ ये हमारा टाइगर ही है, एक बार उड़ गया तो वो कुछ भी काम करने देगा तुमको, वो सोया है तब तक एग्जामिन कर दो, ये उसको सिविली बताया तो उसका इम्पोर्टेंस माँ को समझता है. She understand how seriously we are looking at it, and then you come up to a conclusion that air entry is equal, respiratory rate is normal, calculating the rate is vital in respiratory diagnosis. Normal rate and problem, abnormal rate and problem. How much abnormal rate is there? The severity of our disease diagnosis depends on that. So, examination under sedation is also required sometimes. I must have done maybe once or twice a month. I have to examine some child. When you see hundreds every day, महीने में एक दो बार तो एक बार दो बार तो ऐसे बच्चे आते हैं जिनको अंडर sedation एग्जामिन करना पड़ता है. यू हैव टू टेक टाइम, हरीडली 1 मिनट में नहीं कर सकते. उसको साइडिंग में डालना, उसको बोलना कि मैं सब गर्दी निकाल लेता हूँ, बाद में तुम्हारे बच्चे को जांच करना, क्योंकि उसकी जांच करना इम्पोर्टेंट है मेरे लिए. और देन आई कैन कम टू अ कंक्लूजन आगे क्या करना है. So that is regarding respiratory noises. It's a very important topic for pediatricians from examination point of view, from practice point of view, from expertise point of view. And expertise never comes overnight, comes by practice. So you have to auscultate many babies. For no reason हो पूरे वार्ड का राउंड लेना है ऑस्कल्टेशन, हर एक एज में डिफरेंट रहता है. एडल्ट का ऑस्कल्टेशन मेरे को प्रैक्टिस नहीं तो मुझे आता ही नहीं. बच्चा 1 मिनट में 20-30 बार सांस लेता है, फास्ट रहता है, फट समझ में आता है. एडल्ट मिनट में 10-12 बार सांस लेंगे, घंटा भर रुकना पड़ता है उसका नेक्स्ट सांस लेने. चेस्ट वॉल इतना बड़ा रहता है, कितना कम साउंड आता है कान में. बच्चे का साउंड इतना लगा है कि कपड़े विदाउट निकाल के भी करंट भी लगते हैं. लेकिन व्हेन यू आर मैनेजिंग अ रेस्पिरेटरी केस, अनलेस द क्लोथ्स आर रिमूव्ड, your diagnosis can be wrong. Pleural rub, pericardial rub are other sounds important. Pleural rub synchronizes with respiratory movements. Pericardial rub synchronizes with heartbeats. The easiest way of differentiation. You can ask older baby to hold the breath so that pleural rub doesn't come. You can't ask anybody to hold the heart. Involuntary, voluntary. Pleural rub and pericardial rub are due to rubbing inner layer and outer layer, pleural and pericardial layers over each other. When effusion is there, the sound goes away. Pleural rub and pericardial rub goes away when there is effusion. But at apices you can hear. Still, if you are in doubt, you can concentrate on apices for pleural rub or pericardial rub, because at apices they are being fused together. So that's how we will conclude. It's a matter to be taken very seriously. Bye.